Hello there, my name is Marilyn Barrett, and I'm Director of the Health and Wellness Centre at UPEI. Today I'm talking to you about the primary care networks at Health PEI. The primary care networks were developed in 2010, and that was in response to a number of reasons. Some of the statistics would be at that time, 32% of islanders have at least one chronic disease, and we know that that's actually higher than that now. A third of that group use approximately 51% of the GP visits, 55% of specialist visits, and 72% of nights spent in hospital. The number one reason to be hospitalized in PEI is childbirth. Number two is COPD. Patients with 3+ chronic conditions use 3 times as many hospital or nursing home days, more than twice as many GP visits, and 1.5 times as many specialist consultations than people with no chronic condition. In 2006, Islanders with diabetes stayed 3 times longer in the hospital, had twice as many visits to family physicians and specialists than Islanders without diabetes. Hypertension has been the leading cause for visits to health center. 1 in 5 people in PEI actually have hypertension. So those are some of the reasons why we knew that there had to be a change of some sort in how we delivered primary care in PEI. So in 2008, in the speech from the throne, there was a commitment to build a sustainable healthcare system, one that shifts the emphasis and culture towards wellness and primary care, thereby reducing pressure on acute care. In the Corpus Sanchez report, they called for a renewed model, including strengthened community health centers. And then the Executive Council in November 2009 approved a framework for 5 primary care networks. And then in 2010, the budget was given to develop these networks. And then the whole purpose of these networks is to improve accessibility, promote sustainability, provide enhanced health outcomes, and to give us some more evidence, actually, on what's happening in healthcare. So with the primary care networks, it's an integration of services, accountability, and sustainability. The intent was to build in current delivery sites and augment where necessary to ensure a 30-kilometre radius from a primary care site for all islanders. The 5 networks that are geographically established are West Prince, and then East Prince, Queens West, Queens East, and Kings. Now, Queens East is the smallest geographically, but it's probably the most populated. That includes the Charlottetown area. And so the idea was that we'd have similar population sizes, equitable staff, and resource allocation. You do your best to do that, but not always is that possible. So the idea was that there would be these 5 networks, and each network would have a hub. And then the hub, there would be satellite sites. So for instance, in West Prince, the main site is in O'Leary. There's also a site in Tyne Valley. There's a health center up in Alberton at the Western Hospital, and then there's outreach done to Tignish. In East Prince, the Harborside Health Center is the main hub, and then there's a health center in Kensington and one in Wellington, and then they also do some outreach to Slemon Park and Croppo. So Croppo, we can see here, is on the line of Queens West and East Prince. So sometimes the staff could come from either area. But the hub is actually in Hunter River and 4 neighborhoods for Queens West. So it's our largest area in terms of population between it and Queens East. So there's a new health center in Cornwall, there's a health center out in North Rustico, a new health center in Croppo, and 4 neighborhoods in Charlottetown. There are no physicians at 4 neighborhoods in Charlottetown, but there is an NP no, I guess the NP doesn't work out of 4 neighborhoods, but the diabetes program operates out of there. So then Queens East, your hub is in the Polyclinic, and then there's also outreach down at the Boardwalk, and over to Stratford. It includes Stratford and out to Belfast, as far as Belfast. And then in Kings, your hubs are in Montague and Surrey. With there is a clinic. There's nobody operating out of that clinic in Murray River, but there is a clinic there. And then there is a clinic in Morel that's on the border of Queen's East and Kings, and I believe it's staffed by the Queen's East staff. So the idea is to have a hub in every geographical location and then have some satellites that work together. The programs and services are clinical and medical-based services. So you have physicians and nurse practitioners, health promotion and prevention, chronic disease prevention and management. So example like diabetes educators, COPD educators, targeted screening programs, and services to specific populations, example Aboriginal, immigrants, and Francophone. In terms of provincial, community mental health and community nutrition and public health programs, they're not part of the networks, but they all work together. Very highly collaborative, well-developed chronic disease prevention and management protocols, and working on making sure there's good capacity to respond to patients' needs on an urgent basis. So a typical network would have like a manager and administrative clerical support, a medical director, a nurse clinical lead, a network admin supervisor, and secretaries, clerks. Your core team would be 4 to 8 family physicians, nurse practitioners, registered nurses, LPNs, diabetes educators, and administrative and clerical staff. So areas of particular focus is access, making sure people have access. It's not much good having a primary care provider if you can't get into them for a month. So access, having access to the right provider at the right time at the right place, trying to move people away from physician only. Perhaps it's a dietitian that they really need. And so trying really hard to make sure that people are seeing the right people. Improving health outcomes, decreasing the burden of disease, and prevention and management. And some of the ways they do that is through lean projects, using lean methodology to improve access, changing the hours of the clinics, adding evening where possible, all clinicians practicing to their full scope. The addition of NPs has been very helpful, and there's a provincial patient registry. Some of the types of projects done in the primary care networks over the last number of years include COPD program implementation, hypertension clinics, obesity, heart failure, diabetes, sea change, and improving health literacy. So those are the highlights. And so anyway, I hope this has been some help to you. And certainly you can reach out with questions through Tracy. And best of luck in your studies.